and it's obviously our March meeting. So I think Melanie's probably got the most appropriate background for anticipating a little bit of spring sunshine, although it doesn't particularly feel like that outside. We have had some apologies for absence. So Chris kindly shared with us, Chris Davison, that Zoe will be joining us, but hopefully joining us at various points during the meeting, but can't be with us throughout. We've certainly had apologies from Matt Gelby, Richard Amponza, Krishna Yathiraj and Lloyd Cox, and also an apology from one of our non-executive colleagues, Saqib Ali. So today, just to remind everybody, there is no private session of the council today, so the whole meeting will take place in public today, and will run to about 1 o'clock. And actually, what's really good is it gives us an opportunity as part of the agenda of the council today to talk about our priorities for the coming year, and that's one of the sessions that I'm really looking forward to, because it's a really important opportunity for the council to help us think about that going forward. We do have some breaks planned, and just a reminder also that the session is being recorded, and I think the transcription hopefully has already started. I also wanted to particularly welcome Tim Harrison. So Tim is actually one of the colleagues that our Council of Governors helped to appoint very recently, along with Robin. Colleagues will have already welcomed Robin to a meeting, but Tim hasn't actually officially started with us yet, but he's very kindly joined us today, and I just wanted to welcome him particularly as one of our new Associate Non-Executive Directors.
Thank you. Good to meet you all.
Welcome, Tim. I think we did invite Jo Lancaster as well, but I can't see Jo on screen, so I won't highlight her presence at the moment. But if I spot that she's here, I will. I will let you know. The only thing I did want to mention before I started is I have been struck down by the COVID. So I am carrying a bit of a COVID infection this week, which was a timely reminder 3 years since the COVID pandemic started back in March 2020, that we are still dealing with that. If I'm a little bit slower to the mark, I apologise. It's been a slightly tougher week this time round with COVID than I anticipated. But hopefully you will all support me through the meeting, as I'm sure you will. And I am feeling much better than I did earlier in the week. So I just thought I'd share that with you, because it does seem a timely reminder of the things that have changed over the last 3 years. Okay, so item number 2 on the agenda is our declaration of interests. We've recently asked governors to review and update declarations, and our register of interests is shared. David, did you want to comment on that?
I just perhaps should say that for 1 year I'm serving on the Commonwealth Advisory Committee on Health, which is a meeting with officials of government departments in the Commonwealth, or a select number of them. And I'm this year representing the civil society structure. It's just a 1-year term, which feels very short and hardly enables you to do anything. But I don't see that it has any problems here, but I suppose I should declare that as something which I'm doing in my role as a member of the board of the Commonwealth Organisation for Social Work.
Thank you very much, David. That's helpful to note. Now, if anyone else has got any interest they particularly want to declare in relation to items on the agenda, I'll pause to give you an opportunity to do that. Otherwise, we will crack on to item number 3, which is the minutes of the previous meeting. I don't propose to go through all the individual pages and check with you whether you have any points to raise, but I will pause a moment just to check and ask you whether you're content that the minutes are an accurate reflection of our last meeting in January. Obviously, if you've got any points of accuracy you wish to raise, you have an opportunity now. Everyone looks like they're okay with those, so I'll take it then that we're happy to approve those minutes as an accurate record of our meeting. So moving on to item number 4 on our agenda, which is the action log and matters arising. So we, I think a number of the actions that we had on our log are actually closed. So the first of those was relating to the constitution, the changing of the constitution changes that we agreed last time. So that's been done. And then there are a couple of things ongoing. So action 61, governors to be asked to sign the new code of conduct, which we agreed at the last meeting. I think we have had a number of those returned. It's particularly important for governors who are continuing to remain in post. Did Joe or Tracy, Joe Coldclough or Tracy, wish to comment on how many we've now had returned?
Yep, so we've had 16 as of this morning returned, so there is still some outstanding. Great.
So just a reminder for everybody that it'd be really helpful if you haven't already done so to sign the revised code of conduct, which is the version that we agreed at the last meeting in January. And obviously colleagues from the team will just highlight to you if you haven't done that as well. Action 62 is proposed for closure, and the meeting on carers and carer governors, which was again a conversation from the last meeting, actually took place yesterday. So perhaps as part of that, I know Mark has got a slot later on in the meeting, so perhaps Mark could let us know how that went. Action 63 is not yet due, although that is something we probably just need to again think about how we take forward. And then matters arising, governors have been approached to join the new standards group, and a few have since agreed to join. So that's the action log. Is there anything else relating to the action log or matters arising? Chris, did you want to come in?
Yes, if I may, please. Just I was looking through the papers last night, and on page 10, under COG 2310, we had an update from James and Julia regarding the NED risk and assurance topic on the quality and safety review of mental health, learning disability and autism units. I did see at the end of January that Maria Caulfield, the government's mental health minister, had announced what I think is a further review into mental health inpatient settings due to concerns, some well publicised issues across the country regarding patient safety, experience and quality of care. This may well be in the agenda, covered in the agenda and papers later, so my apologies if I've missed them, but I understand this supersedes the September 22 review, and will be led nationally by Dr. Geraldine Strathpey. So I would like to clarify, firstly, does this supersede that review? And will governors be cited on the findings of this review? And what is the scope, and what will we be expecting to see? Thank you.
You're on mute, Christy.
My apologies, I've made the first faux pas there and keeping myself on mute. But James Mullins is with us, our Group Director of Patient Safety. James.
Thank you, Krishna. Thank you, Chris, for the question. The short answer is we're not quite sure yet. I attended the round table last week that was chaired by Dr. Strathdee, and all what we're sort of doing at the moment nationally is understanding what sort of data sets would need to be looked at as part of any continuation. That's the key word. It's a continuation of the quality and safety reviews, and it's looking, as I said, very specifically at data, particularly around mental health and learning disability in patient units. So I fed in from NHFT and LPT's perspective the work that we have done, where I feel from an organizational point of view data needs to be looked at. And I spoke to both Tanya Hibbert from LPT and Anne Rackham from NHFT about their thoughts as directors of mental health, and I fed those in as well. So it's kind of wait and see at the moment, Chris, and once we know more about what we'll be asked to do for the review, of course that will be shared more widely.
Thank you very much.
Thank you.
James.
I think you can see. Oh, sorry, Krishna, to cut in. I think Gavin has expressed, as you can see from the minutes, this is a concern for us collectively. We're pleased to receive the levels of assurance that we get as governors, but it's something that I would be grateful through you, Krishna, if it could be logged as an action that we could have as a matter arising at future meetings, please.
Yes, thank you, Chris. I think Angela would like to come in as well.
Yeah, just to say that there is going to be, and already commenced really, a national programme on inpatient care. That's being led by Liz Durant from the national team. And James, I know, is connected with her. I certainly have, and with others in relation to that work. But that is welcome, because that will be, an investment programme around some of that focus, Chris, and that quality, which we know that, if we take services like CAMHS, workforce may leave inpatient care earlier to go into some of the community provision. So really welcome the focus on inpatient provision in the way the national team's steering it.
Thank you.
Thank you. I mean, I think really important to say that clearly this has been a big part. This has been a big focus for inpatient mental health services throughout the months. As you all know, and I think James mentioned obviously last time as well, that we are, the CQC will undoubtedly be continuing to keep a close view on data and the risk profile of the trust and all mental health trusts regarding these sorts of issues. It will be very high on the board's agenda, so I'm sure that as part of Angela's regular updates to the council, she will be in a good position to keep you and along with other exec colleagues cited on any developments and concerns around that. So I think as part of that, we can make sure we keep you up to date. Joanne.
Yeah, can I just ask a quick question to James? James, in those conversations, was there mention of compassionate care in those settings? Because with that client group, it is sometimes difficult for staff to always demonstrate compassionate care, because when the mind is in a very difficult place, then staff at times have to stand up to those patients. So I just wanted to know about the aspect of compassionate care going forward with that in that agenda.
Yeah, that came across loud and clear, Joanne. It's certainly in the roundtable that I attended, where I fed in really clearly my thoughts on capturing patients and staff voice as part of this. And as you probably know, this is some of the work that we are doing internally at NHFT as well, in terms of how we collect that ad hoc feedback from both staff, patients, families, service users and carers, and how we improve the sort of formal feedback routes as well. Not only, for everybody, but, a real focus on those that with communication difficulties, for example, that may struggle to do that. So yeah, that was all absolutely fed through, Joanne.
Yeah, thank you.
Thank you very much, and thank you, Chris, for prompting that matter arising. So we move on now to section 5 of our agenda, which is the Director of Corporate Governance report. And I'll hand over now to Richard Smith, please.
Thanks very much, Krishni. Good morning, everybody. I wanted to throw out 5 things from the report this month, which you'll find in paper D in your packs. So the first of those areas relates to our governor elections process, which you've hopefully noticed through the various campaigns that we've been running over the last couple of months. So you'll note in the report that I've signalled that several of our current governors will be leaving the council over the coming month in April as their terms come to a natural end. And I just really wanted to thank all those governors that will be leaving us at this point for their substantial contribution to the council and to the trust over the last few years, especially when, as Krishni alluded to earlier, we consider the disruption we've had to contend with through the COVID-19 pandemic. I suspect, like everybody else, I'm tremendously proud of what we've been able to achieve together over this period, and just wanted to thank those governors that will be leaving us, and hope they'll continue to remain involved in the trust, be it as a member or in some other capacity into the future. So thank you very much. Before I hand over to Tracy, just to give us an update on where we've got to with our current elections process, I was just going to bring in Chris, who I think had just a few words to say. Chris, can I hand to you?
No, sorry, could you go on to, sorry, you've thrown me a bit there. could
Do we do the elections update first, Chris?
Yeah,
yep.
Then if you don't mind.
No problem. In which case, Tracy, are you able to just give us the latest position on our elections campaign, please?
Yes, so the nomination period closed on last Friday, so Friday the 10th. We had 11 seats up for election, and as it stands, we're still waiting for official confirmation for Civica because the withdrawal date was yesterday for candidates, but 9 of the seats will be filled, so that's a good success. And we have 1 contested election in Kettering and Corby, so that will now go out to votes. And then we'll proceed with the uncontested seats to get them sort of the letters, official confirmation letters, and starting to arrange the induction periods. But the launch of the voting for the Kettering and Corby is, I think, the 30th of March. So but that's due shortly. So yes, we've got 2 vacancies left after the elections, but 9 of the 11 seats will be filled as it stands.
Thanks very much, Tracy. That sounds like a pretty good position. And of course, just to remind colleagues that we're of course recruiting to the vacancies our New Look council, having amended the constitution in line with the decisions made at the previous council and board meeting. So yes, for those in that constituency, do look out for your ballot papers. I suspect probably via email actually in the new world over the coming weeks. Chris, shall I hand to you at this point then, in which case?
Yes, please. That's much better timing. Thank you for that's appreciate it. I did ask for Krishni's agreement and Richard's to say a few words. I promise it's not an Oscars award speech, but after 5 years, I am grateful to be able to say a few words on a role that is close to my heart, as this will be my last council meeting. I have made a few notes, so please bear with me if I've got my eyes down. First of all, a few thank yous, a big thank you to all the governors I've worked with, particularly those in recent years, too many to name individually, and for those who are standing down this year. Thank you for their time, their energy, their enthusiasm, and the interest they've shown in the work of the NHS and NHFT. It is not an easy job at times being a governor. Also, a big thank you to Richard, Tracy, Nikki Hitchcock in the FT office, to Ali Bosworth, who was around when I first started, and more recently to Joe for their support and encouragement. Thank you too to Krishni for your support and encouragement during this time, and with the board of directors. And one of my proudest achievements as lead governor is supporting the trust in establishing a dedicated governor and members lead, a post which Tracy now very capably is now in. Look, as lead governor, I have no rights or privileges than any other governor. As I said at the January council meeting, I haven't got everything right, but I've learned a great deal. And when I've needed to act as a spokesperson for governors, I've done my best to offer a collective view. Our joint work recently on leading and revising the Annex 6 and Code of Conduct with Peter Howie was an important and much needed piece of work, and I'm pleased that we've been able to bring that to conclusion. And I'd like to think that the relationship we now have as governors with the board is in a much better place than when I first started. Looking back on my 5 years as public governor, I am particularly proud of probably 4 or 5 things. Firstly, in 2018-19, pre-pandemic, bringing together partner organisations to host health and wellbeing days at Kettering Library. Age UK, Northants Carers, Kettering Mind, the public health team from the former county council. NHFT services, both physical and mental, together with the colorectal cancer screening programme from Kettering General. I really took to heart the need to promote prevention, early intervention and signposting. And during 2018-19, the ability to talk with members and recruit new members under various public-facing community engagement events, recruiting something like 250 new members to the Trust. In 2019, working with the Trust teams in arranging with the Saints for our 2019 AGM to be hosted at Franklin's Gardens, and working with the Saints Chief Executive Mark Darbin for 3 of the first team players to talk about the pressures of being an elite sports person. It not only left a lasting legacy, but raised awareness of men's mental health, and whereby today our IAP service at NHFT works with the Saints Community Foundation on community-based programmes. During the pandemic, when the public clapped the NHS every Thursday, but only saw the NHS as doctors, nurses, A&Es and ITUs, I was pleased to work with a staff governor colleague at KGH and our own NHFT transport team to ensure gifts and food donated in Easter 2020 that were piled high at the KGH Staff Social Club were redistributed to NHF staff across all sites by way of a small thank you. In 2021, 2 years ago, working with local community groups in taking over an unused shop in Kettering High Street to create a health and wellbeing information hub. Again, partner organisations such as Age UK, Northants Carers, the new Northants Public Health Team, NHF School Health Team, again to promote prevention, early intervention. And as I said at the time, a passion of mine, which I was able to see to fruition, was around hashtag health on the high street. And a particular pleased to see at the week we had the Health and Wellbeing Week with the Northants Council, working with a former carer governor who was a parish nurse in offering free blood pressure monitoring checks. Of the 50 people tested that week, 75% had high blood pressure, and we were able to signpost them to their GP for appropriate treatment. And if that's not population health, then I don't know what is. I'm coming into land now, but after all of these events, you know, a site, I remember going on a service visit to HMP Littlehay, where I saw the NHF team treat the person first, the patient second, and the offender last. Very proud moments. But what I'm most proud of is the conversations I've had with the people I represent, members and members of the public for Kettering and Corby and beyond. And I would like to end by sharing one such conversation at one of these health and wellbeing events at the pop-up shop in front of the NHFT governor's store. A lady came into the shop and said, "Can you help me, please? I am struggling with anxious and intrusive thoughts and I don't know what to do." I said, "Madam, walk this way." And there is the NHFT IAP team. We were able to offer immediate support and reassurance. And what is clear to me is that despite our best efforts, people do not know where to go to access services. 20% of what makes us healthy only comes from healthcare when you think of the wider determinants of health. And it is clear that post-pandemic that the colour of people's skin, disability, social circumstances and digital exclusion mean that there are sections of our community that need advocacy. And we need to go where the people are at. And I'm hoping that the work through the integrated care systems, local area partnerships will help to that. As governors, we're not just representatives of NHFT. We are ambassadors of the wider NHS, and we are in the peace of mind business. And I can think of a dozen or so off the top of my head, conversations like that. And that is what I'm most proud of, and acting as a bridge between the NHS and the community. The NHS is a demanding, unforgiving environment. It's relentless, and I wish every member of staff well in every corner of the trust in the work that they undertake. And I hope to continue my association with you in some way, form or another, because I've been proud to be a public.
Thanks very much, Chris. And you may see some support in the chat, which of course people on the recording won't see, but yeah, lots of kind words here, I think reflecting your work and the work of others actually over the last several years. So thank you very much indeed. Lots of clapping hands here on the screen, which is great to see. Moving on then in the corporate governance report, it's probably worth mentioning at this point, given Chris is stepping down, what we're doing in relation to the lead governor position. So you'll see in the reports that we wanted to ensure that there was an appropriate transition from Chris leaving to a new person taking up the reins. And given we are having a number of new governors joining at the end of the elections process, we wanted to hold off immediately filling the lead governor position, and instead are opting to fill the deputy lead governor position. So what this means is, in accordance with the procedure laid out in Annex 6, we'll be inviting expressions of interest from elected governors. I think we're starting that process early next week to stand as the deputy lead governor for the council. This will enable us to have a handover with Chris, and for that person then for a period of time to be acting lead governor. And once we've then got the new council installed, we'll of course then be moving to recruit to a lead governor position in time. But I just wanted to flag both the opportunity and the timeframes which you'll see set out in the report to encourage people to put their name forward. The third area I wanted to highlight relates to non-executive directors. As Krishni mentioned at the top of the meeting, we're pleased that Robin, Tim and Joanne have been able to join us today. Of course, this is part of the key role of the governors in appointing non-executive directors. So I just really wanted to welcome formally Robin to his first council meeting in post, and also to welcome Joanne and Tim, who are observing today, and will be starting formally over the next few weeks. The fourth area that I wanted to highlight in the report relates to in-person activities. We've had lots of discussion, and Chris has alluded to this, I think, in his remarks regarding the need to reintroduce some in-person activities to the council's work plan. I'm pleased that we had a productive meeting in February. A number of governors contributed to that, along with non-exec director colleagues. And within the report, I think it's on page 5, we've set out the outputs of that discussion, which you might regard as a menu of options really for in-person activities over the coming year. We are, as we mentioned at the workshop, trialling the pre-employment occupational health individual risk assessment process at the moment to ensure that it's tailored to the needs of the governor role, whereas at the moment it's largely designed for staff. Once that's in place, that then ensures that we're able to make any reasonable adjustments that are required for governors to keep everyone safe as we start to initiate in-person activities. And we're hoping that will start with in earnest really in the new financial year in April. The final area that I just wanted to draw out of the report is the welfare protocol. This piece of work goes hand in glove with the piece of work that Chris mentioned we've been working on governor conduct. We are planning for the workshop on the 4th of April, which we are pleased to confirm that Peter Howie, who many of you will have worked with before on the Governor Conduct Work. Peter will be running this workshop for us on the 4th of April, which is where we're going to look at the existing Governor Welfare Protocol and essentially refurbish it really to make sure that it's fit for purpose for what we need over the coming year. So I'd really encourage governors that have an interest in this area, irrespective of whether they will continue in post after the end of April, to contribute to this workshop. If not by attending, then by sending us some comments, thoughts and feedback that we can include in the discussion. This is an important area of work for us, and we'd hope then to be able to bring this back to the Council at a future meeting for approval. So I think those are the areas I wanted to draw out in particular. Christian, of course, as ever, happy to answer any questions either on those issues or on the report more generally. Thank you.
Thank you very much, Richard. If there are any questions, there's an opportunity now just to highlight anything. Chris?
Yeah, thank you, Christian. I've got my composure back now. Sorry, I was being authentic, and just really to reassure governors that the proposal about the deputy lead, Richard has discussed with me in full, and that has my full support. So although this is my last meeting formally in COG, my last day will be, I think, Tracy, is it the 22nd of April?
23rd.
23rd. Oh, I've got an extra day. So I've got an extra day. And when I made the decision to stand down, one of my principles was that I wanted to provide some continuity, some leadership, and also some to support the transition arrangements. And in terms of this interim period, as you can see with the timetable set out, that this will allow people to come forward. It's, I suppose, as lead governor, you can see from the summary in the one of the appendices to Richard's paper that there's an external and an internal. As lead governor, it's like the break glass in an emergency for NHS England to contact you in the event of an emergency, which has never been the case or needed, but needs to be there as a matter of last resort. But more importantly, internally, is acting as that bridge between the board with Krishni, the non-executives, and also supporting colleague governors as well. So you may wish to stand as a deputy lead, if you like, to hold the fort. There's no long-term commitment. You may wish to step down when a lead is elected from the new council, but equally you may wish to go forward to stand as lead governor. So I just wanted to reassure governor friends and colleagues that this is has my full support. Rich has discussed it with me, and I think this will help in managing that transition. And within that timetable, it will also allow probably a week. So when the voting closes Friday the 14th, appointment elected on the Monday the 17th, that will allow a week for a handover with me as lead governor as in terms of current issues and any other outstanding actions that need to be taken. So I just wanted to add to that. Also, fully welcome the commitment to getting back to meeting in person. A lot of governors spoke up at that workshop we had. We are volunteers. I think, being able to meet in person would add a new dimension. To put all of our transaction on the screen is difficult, and we haven't been able to build relationships and friendships. There's people leaving as governors who I haven't met for 3 years. So I really welcome that commitment, as I know other governors do, to getting back to face-to-face and in-person activities. So thank you.
Thank you very much, Chris. That was really helpful, particularly I think highlighting the transitionary period and the deputy lead governor opportunity in that context. And I think Chris also made an important point in saying he's not going anywhere for a few weeks, although this is obviously the last formal meeting for many of you, and it was therefore very, very important to recognise the fantastic contribution from so many governors who are going to be stepping down. We look forward to kind of working with you still in the remaining weeks, albeit there's no formal meeting taking place. There will be some other things certainly still that we're working through in these remaining weeks. I also just wanted to add my thanks to Chris on behalf of the board. and indeed to all the other governors. I mean, looking at the names of governors who are stepping down, I mean, what a contribution, particularly in terms of recruitment of non-executives. You know, there are a lot of non-executives who wouldn't be here in this room today if you guys hadn't been involved in the process for appointing them. And that, you know, I can't emphasize enough how important a contribution that is, because, you know, that is the way in which you significantly influence the board of directors, amongst many other opportunities. But that really is very critical and very important for the governance and leadership of the organisation. So, you know, in many ways, I mean, I remember Helen, it feels like ages ago now, but, you know, there was the school project as well. So there are many things we could reflect on. It seems incredible, really, that of the things that have happened over the last few years. And, you know, not least all the work on standards, which, you know, at various points in different guises people have contributed to as well. So so just want to really add my own thanks and hope that you will, as Richard said, remain a friend and member of the organisation, so that we can continue to engage with you in various events and other things that I know we'll be continuing to offer to members. So we move on then to the session 2, which is the strategy and assurance section. So item 6 on our agenda is reports of the chair and chief executive. The reports are available to you as normal. I don't have anything particularly that I wanted to draw to your attention from mine, but it is customary for us to use this opportunity to ask Angela to give us a sense of what's sort of top of her agenda at the moment. So I'll invite Angela in now to share that with us. Thank you, Angela.
Thank you, Krishni, and good morning, everybody. Good to be with you. And if I can just echo the thanks that Krishni's conveyed to all the governors, and you really made a difference, and I hope you recognise that. Chris knows that how he feels about the work he's done, but Chris, have a look in the chat, it's very clear, so please take that moment. Okay, so yes, a few things that I just wanted to highlight, and I think important, Krishni, when you mentioned COVID at the beginning, just to remind us that we still stay in a level 3 major incident position across the country, and I think sometimes that, when we're living with COVID, can sometimes be a reminder that we need, actually, that this is still something that we're living with and operating in, and represents part of the challenges that we are still dealing with in the organisation and across our society. But the areas that I just would want to highlight to governors today are several things, really. There are clearly a lot of work going on around planning and our finances in relation to that. Just to remind people that we received planning guidance just before Christmas, and there is a very clear and tight timescale to deliver that plan. And it's tight in many ways because we have to mobilise an organisational position, but it's tight because clearly we're working as a system partner, and the ICB needs to complete that together. So Richard Wheeler, Dave Mayer, key individuals working on that to understand what does it mean for us in NHFT, what does it mean in terms of our capacity and demand that we've spoken about here before, and what does it mean in relation to our system work that clearly we've spoken about before. But what we do know is that there will be challenge around some of our finances, and I think that's across the whole NHS as a whole and the whole of the care sector. But as we go forward, we'll need to come back to describe and, if you like, provide more detail around that. But I think the value programme we've mentioned previously will be the way in which we drive that through our NHFT organisation. But I know Chris, Richard or Dave would be happy to comment further if needed. The other area that I think is important to share is one that I probably constantly mention is our workforce. Again, really important to thank them so much for what they continue to do to support us. And governors are amongst our workforce, so I extend that across to all of you. But there is no doubt in the challenges that we've got, you know, strikes, we talked about a critical incident last time we met, we talk about the demands and pressures, the challenges people now have in their home lives and at work, it is a really challenging environment, and yet our staff still go above and beyond. And I know that you know that, but I think it's important to keep saying that our staff are amazing. It's absolutely still a privilege to lead the organisation because of what they do. And I'm really pleased to see the results we've got from staff survey, which still put us with above national scores on our people promise elements. And that's a testament to every member of the team at NHFT, because everybody delivers that. Now, that doesn't mean we haven't got work to do. We still have, of course we have, but that is a really incredible achievement. So I'd like to say thank you to all the staff, but that remains an area of focus for me in terms of how do we continue to support our staff experience through this next period as we go forward. The other elements that I think are important for me to signal are areas around children and young people. I think this is an area that I recognise is a risk for us as an organisation, because this is an area where we have to deliver so much in partnership, and we know that children and young people and the impact for them is still very, very real and still yet to emerge fully. So I'm really pleased that the system is working hard together to understand those risks together and to focus more than it perhaps has on children and young people in the future. And I look forward to that work coming forward and the role we can play in it. And then the final thing that I would mention is around how, and this is something that as a team we're continually grappling with, and the organisation too, is how we stay focused on the here and now and the busy environment that we have, but equally how do we prepare for the future? And that we're creating the hope, creating the strategy, which I know we're going to hear about soon, but we're also creating the sort of milestones that we need to take on that journey. And that's something as Chief Exec that I'm thinking about constantly. Where do we need to be in 3 years' time? How do we recognise the goals and the steps that we need to take to really make sure we take the right steps in this next period? So I think that's what I will finish on, Krishni, with just a final reminder that we've got the Virtual Wellbeing Festival in July. We're doing it again as a system, and I would encourage governors to get involved and to participate if you can as well. Thanks, Krishni.
Thank you, Angela. And obviously you've highlighted the staff survey results in particular, which are obviously a really important information and news about that has been emerging now over the last few weeks. Just to mention that the board will be discussing the results in public at its board meeting at the end of March. I think it'd be great if governors are supportive of this, for us to perhaps bring that then as a topic for assurance to the council in May. I think, Richard, we've normally done that in previous years. So if you feel it would be helpful for us to do that, because for all the reasons that Angela said, the staff survey is obviously a very important piece of insight and intelligence on how our people are feeling at the moment, or certainly did at the time of the survey, and actions we need to take on staff engagement. So, as I say, that topic will be very much part of the board discussion in March, which obviously you are most welcome to observe as governors. And then we will hopefully, if with your agreement, bring that to you for discussion at the May meeting. So there probably are a couple of questions. So first of all, Joanne Dalrymple-Smith. Jo.
Yeah, just to feedback on a really positive bit of information. Last night I was talking to a friend, and she outlined and shared about the mental health support teams that has just written out to all parents and shared a really comprehensive questionnaire that outlines exactly what the framework is for the school to engage with, including pictures of who's in the team. And she was just buzzing about it. So I really just want to be really positive and feed that back, if that's okay.
Brilliant. Thank you, Joanne. always great to kind of get a live example of something that's kind of working through at the moment and being pushed out to support young people in our community. Thank you, David.
Yes, thank you, Krishni. The live example, a qualitative response, and the survey is a quantitative response to data, and it's always good when they come together. And I've taken a professional interest in workforce issues over the last 20 or 30 years, nationally and internationally. And I just want to add, I've already written to Angela about this, but I want to add how significant it is to get these sorts of results. It is far from inevitable. It doesn't just happen. It happens because there is a strategy which is deployed by management and staff, and it doesn't happen quickly. It's something that's built up over time. And it feels like a very significant achievement. And it's about, I believe, the most important thing for working in our sector, and that's the people and the team and how people work together, how they respect each other and how they respect the service users, the public and everybody else. And as a governor, I'm very proud to be associated with an organisation that has that achievement, and I wanted to pay tribute to the management and the board and others who have enabled it to happen, and indeed everybody, because it's leadership that is crucial, but it is how people respond to that as well. So I think we should minute that as something that we've noted as significant and gives us significant assurance for the future, which also means finally that you have got to pick up the problems when they will arise. There will always be problems, and the test of a really robust system is somebody that can pick up the problems, deal with them in a proper, effective and sensitive way, and still maintain that positive environment. So thank you very much, and I'd like us to minute that we appreciate the and recognise the significance of that response, and thanks to all the staff.
Thank you very much, David. That's a very, very welcome comment. And you're absolutely right. I mean, it is something that the trust has always prioritised, and not least, I think, because there has been lots of evidence about the correlation between staff engagement and patient care, and ultimately, that is a really important thing for all of us to recognise. And whilst there are really positive things as well, we also know that there will also be things within the staff survey that we need to act on. So it's a constant approach really to addressing issues and learning from what the survey tells us, and we'll share a little bit more of that, no doubt, with you in the future meeting. I'd love to bring Banu in and just to introduce people, because I think, Banu, this might be your first Councillor Governors meeting. Banu is currently our acting medical director, so delighted to welcome you. Would you like to make a comment, Banu?
Thank you, Krishni, and I completely echo with the point David made, that in terms of the kind of how the staff can come together, particularly difficult times, when there is that almost support. So the thing that comes to mind is the recent kind of junior doctor strike. I know kind of there are some difficulties and there will be mixed reviews about it. I was given very clear instructions by my two juniors about how to do things and not to mess things up when they come back. So even when they were on strike, I was getting calls to make sure that I was doing my job properly. And it just shows that it's that. And again, the things such as kind of walking into the ward, the reception staff was saying, well, you demoted or promoted, well, you looks like you've done well today. You're kind of going one step ahead in a day. And it's quite nice to see that, and the support on the ward has been fantastic. So I think just kind of shows that there are lots of things, there are lots of strengths within the organization, and for us to kind of keep make sure that we are doing what we are doing, and almost kind of always there's room for improvement. It was really encouraging to see the support from all the staff in a difficult time, and I hope that we are able to, I guess all of us feel the support with say nursing strikes, ambulance strikes, everything else that is going on. I think sometimes these things will actually make us come together stronger, and I just want to make the point. Thank you.
Thank you, Banu. Really, really interesting reflections. I'm glad you performed well on behalf of your team during this very challenging period. Okay, well, thank you very much, Angela, for your comments, and really helpful. I know always Council welcomes sort of the executive input here, just to understand what's happening on the ground at the moment. So we're moving on then to our NED risk and assurance topic, and one of the things that we wanted to cover with you for this meeting was our annual Equality Information Report, which was presented and published after the board in January. So we've invited Judith Seymour, who's our Equality, Diversity and Inclusion lead on behalf of the NED group, sitting on the board, to just share some assurance with you regarding the report that was published and the data that we've collated. So Judith, over to you.
Thank you, Krishni. Good morning, everybody. I was just reflecting on what Krishni said at the beginning with regards to COVID. My son came home from uni on Monday, and we all have COVID because he brought it back from uni. So it is very much with us still, I'm afraid. Thank you for Tracy for preparing the slide and also for running it. There is also, as you're all aware, under section G, a 20-page report summary, which I know is quite a lot of material, but is really, really interesting, and I will refer you to some of the more pertinent parts. Can we go into the first slide, please? Thank you very much. Just a very brief recap of why we're here and why we're doing this. Obviously, as an NHS Trust, we have a legal duty to publish an equality report every year because we're part of the public sector. And the equality duty is really set out in the 3 bullet points on this slide, which is to eliminate unlawful discrimination, harassment and victimisation, advance equality of opportunity, and foster good relations between people who share protected characteristics and those who do not. And the information that is published and that we as a board and as NEDs get assurance on is not just on NHFT employees, but also in any other people affected by NHFT policies and practices. So it's a broader scope than just the workforce. Can I have the next slide, please? This is a very busy slide, and I can't apologise for it because there's quite a lot of information to impart. A little bit of recap before I sort of I go in on the really, really good news is the equality and delivery system is designed to help the all NHS organisations improve the services that they provide for the local communities, and also to provide better working environments free from discrimination and meeting all the requirements of the Equality Act. It has a 4-tier grading system, and NHFT have achieved the second highest, which is achieving, which on a national level is a really excellent place to be. We do need to celebrate that, and we do also need to recognise that it's an ongoing process and we have some ways to go. The equality delivery system has 4 goals, and these are the coloured and numbered paragraphs in this slide. And the 4 goals are better health outcomes. And under this heading at NHFT, we looked at the perinatal mental health service specifically because it's quite a new service, and the staff and the trust wanted to ensure that it was established in a way right from the beginning that it wouldn't allow for all sections of community to be reached. And this service has now been reviewed and patient needs are assessed, and the average rating for the services is achieving. For next year, there'll be another few services that have been picked, and I'll address that later. The second goal is improved patient access and experience. And again, on the slide, you can see an example from the perinatal mental health services, which was recognised as being a really important service. And the patient satisfaction scores have been analysed, specifically focusing on protected characteristics. But in addition to perinatal mental health services, we have also done the same analysis in the I Want Great Care programme, and because I just wanted to ensure that that it was clear that it wasn't just one service that we are focusing on, but in fact several. The third goal is the representative and supportive workforce. We in the report, you'll see we have analysed the representation of our workforce by ethnicity, disability, and identification as LGBTQ+. And the outcomes from recruitment processes have been scrutinised, and all approaches to addressing racism have been considered. There is a job evaluation system in place to ensure equal pay for work of equal value. I just want to add to that the NHFT representation was above the NHS model employer goal of 15% in 5 of the pay bands, and we also have higher levels of BAME representation evident in the higher pay bands, which is very unusual for the NHS. The fourth goal is the inclusive leadership, and this is, I'm really very proud of this, because not only do we have 5 staff networks that board members sponsor and in some cases attend and dip in as much as possible, but we have all individually made anti-racism pledges, which is, in my experience with 7 other organisations I'm involved with, is very, very unique. And I feel very privileged to be working within an organisation that takes its roles so seriously in this field. Can I have the next slide, please, Tracy? For next year, as I've already mentioned, this is an ongoing piece of work, and there are plans next year already. There are a summary of 4 objectives here for next year, which is a continual improvement for the experience of BAME colleagues within the trust. We have picked diabetes and spiritual well-being as services that the trust offers to focus on in relation to objective 3. We want to be able to demonstrate that a minimum of 90% of new or redesigned services have undergone a consistent and robust equality impact analysis. And the other 2 objectives, I won't read them out. I am somewhat conscious of time and want to leave time for questions. But the board has received, and the NED specifically have received, a lot of assurance and that there are very clear plans for the coming year. Can I have the next slide, please? And this is focusing specifically on the annual equality information report that was received by board in January, of which you'll see the summary, which I've already referred to. There have been some really positive changes in relation to increased representation of colleagues from BAME backgrounds, and that's predominantly in the middle and higher pay bands. There's been an increased number of colleagues sharing information on whether they have or suffer with a disability or living with a long-term health condition. There's been an increased focus on the trust becoming more LGBTQ inclusive, and I'm actually wearing the lanyard that has come with me completing LGBTQ+ training. So to those who are able to visit the trust, if you see staff members wearing this, we have all completed the requisite training, which is really, really interesting. And there are also new inclusivity workplace initiatives around inclusive recruitment. So a lot of really positive changes. Now, on the slightly less positive, where the data has remained very flat, is on the right-hand side of the slide, is where we are not our patient ethnicity profile. We've not really been able to make too much of an inroad into ensuring that we get a good understanding, and you'll see that from the report, across the board. And we therefore continue to feel that we are not either certain segments of the population not actively seeking NHFT services, but we're not reaching certain segments of services. So that's one area that there'll be a focus on, and further support is needed for all staff in response to any form of abuse, including racial abuse. And this is progress through the Staff Safety and Security Group. In fact, it's something that we're going to be discussing at the next Quality and Safety Committee. For further detail on this, because there's some really good detail in the report which was included in the pack, at page 14 and page 18, there is further information on the NHFT Equality Report for the breakdown of staff diversity profile, and on page 19 for the patient diversity profile. And page 15 and 16 have a really good summary of the equality initiatives the trust that we have been working with. So please, if you don't read the whole 20 pages, those pages specifically are quite interesting. Can I have the next slide, please? Thank you. And so in conclusion, real summary, won't be reading the words. As a workplace, we have increased the number of colleagues in high pay bands and mid pay bands who come from BAME backgrounds. We're going to be working to progress addressing inequalities in mental health services and access with those from those who have suffer with a disability, and we remain committed to achieving equality objectives for the coming years. Now, those are all, really lovely conclusions, but in addition, and I really hope I'm not stealing Angela's thunder here, but since the report has been a number of other things that have occurred that have been really positive in this area. Angela's report contains two of them. The first one is recognitions from the Midlands Inclusivity and Diversity of Award Scheme, who have commended our influence on the positive impact on workforce experience for colleagues with ethnic minorities. And the NHFT Head of International Recruitment, sorry, not NHFT, the LPT Head of International Recruitment, Asha Day, was awarded the Equality, Diversity and Inclusion Champion of the Year. What is not currently in Angela's report was that we have been working with meeting the 8 areas of employment policy and practice with Stonewall to be recognised within their UK Workplace Equality Index, and we have achieved not only a gold award for that, but also are in the top 100 of employers, ahead of NHSE, in fact. So it's a really super achievement that definitely needs a lot of praise, encouragement, and celebration. I've included in the last 2 slides, which I will not go through, some further examples of work, equality work, and examples of what's been going on across the trust. And I'm sure that these slides will be shared with you, but they focus very much on continuing equality work and ensuring that both staff, the workforce, but also the patients, the service users, and the community feel that they feel that they can approach the trust and that they are treated with respect and inclusion. Thank you very much. I'm really happy to answer any questions that I can. So happy to. Thank you very much for getting rid of the presentation so I can see people.
Thank you very much, Judith. That was really helpful, walking us through those and highlighting some of the achievements there very, very clearly, but also where we've got work to do, because, clearly this is an ongoing, as with all of these things, this is, the work doesn't stop. It's something we are focused on as a process of continuous improvement. If anybody would like to ask any questions, and I'm sure that Judith would be happy to answer them, but also other non-exec colleagues might want to support with that as well, because it's important to say, whilst Judith does take a bit of a lead on this on behalf of the group, this is a really important priority for all of us, for the board, and it's really something we continue to focus on as a matter of priority throughout, because I think, as colleagues have already said, you know, creating a culture of compassion and inclusivity is sort of fundamental, really, to the success of the NHS. Okay, so a few comments and thoughts from people. So first of all, Helen.
Yes, I was just interested to understand, because the report is very comprehensive. There's a huge amount in it, and it's very impressive, the work's being done. But I was interested to understand how it's linked to or aligned with the staff survey, and how the results from the staff survey inform the work of the equality initiatives. So really, because the report stands in one place where it looks at measurements and data, and we've got all these people at these different levels, but what's the effect of that on the staff? Do we ask staff in the staff survey what their experiences are of the work that's being done?
Thank you, Helen. Do you want to come in on that specifically, or do you want to wait and hear a few questions? How do you want to play it?
I'm happy to hear some more further questions.
Okay, Helen, we'll maybe get a couple of comments, and then Judith and others who want to come in. I can see Melanie wants to come in as well, so there might be a couple of different responses to that. I'll bring David in, because I can see Chris Oakes would like to come in as well. So I'll probably bring Chris, Judith and Melanie in at the end to respond to a range of these things. But David Jones next.
Thank you, Krishni. I've got a comment rather than a question, but thank you very much for the report and the overview, which, as was said, it links in with the staff survey. As a governor, and knowing that staff are listening, I just want to say that I think the NHS is incredibly, and its staffing, dependent on recognising and indeed celebrating the diversity of our workforce. We know we cannot deliver health and social welfare without that respect, and people who do not do it get into trouble, serious trouble. I think as a governor, as a member of the community from a city which isn't the most diverse, a town which isn't the most diverse in the country, but is significantly diverse, this is really important. And I believe our country is at a very difficult and a potentially dangerous time. And I hope that from the governors we can say to our staff that we value and respect all of them. It's really important at this time that we use the language carefully, and that we talk positively about the values of diversity. I happened to be at a Commonwealth reception on Monday, and I happened by chance to bump into the Foreign Secretary as I was going down the stairs. And I said to him respectfully, many people are deeply troubled by the language ministers are using about this issue. And he listened to me carefully and responded positively. But I want staff to know that governors will not, or certainly I will not rest while there is a difficult language being used. We value everybody, and at this time we need to speak up and say this publicly, because the public discourse is important. I'm not asking for any response from Krishni or from Andrew about that, but I hope that people will recognise that people see this as really important, and that we do need to be speaking up. And I really value this report and the way that the organisation is being led to address these issues. Yesterday was the International Day to Combat Islamophobia. We know there is a rise in attacks on Jewish people and anti-Semitism. We cannot let this rest. We have to be vocal about it, and I hope it's helpful that I have been. But thank you very much for the opportunity to say it.
Thank you, David. I think you're right to highlight that language is important, and it is important for our people, and it's really important that we are cognizant of how our words can affect people's feelings of well-being and how people feel included within our organisation, and celebrating and sharing people's different cultural experiences, which actually I do think can be incredibly powerful. I haven't forgotten the wonderful Diwali celebration we did last year, which I just remember the impact it had on people, and it just reminded me how powerful these things are. So thank you, David, for your comments. I'll bring Chris in, and then perhaps we can round off. So Chris Davison first, and then perhaps we can round off with other colleagues from the board. Chris.
Yeah, thank you very much, Krishni. And David, thank you too for saying what you did. I applaud that. And I think we as governors collectively, that is something that we share about the language we use. We know from our experience in the NHS that we need to celebrate diversity in all forms. And I think the report, really helpfully goes to address what work is going on. Helen put the question much better than I did about the way that this relates to the staff survey, because I was keen to sort of cross-reference this with the staff survey results, but I couldn't access the link that the FT office came out. So I think, again, the commitment, Krishni, that the board to bring this back to the council is welcome. My actual question is around, I think in the conclusion, you talked about the patient profile data set. And certainly when I talked about my reflections as a governor, my experience at these public-facing community engagement events, that race, colour of people's skin is a barrier to access. And I wondered, and it might be in the report or I haven't seen it, is that in terms of the commitment to looking at the sort of inequalities in access, is there a base point that you start from and therefore are looking to improve it by X% or go from 5 to 20? It'd be helpful to have a little bit of colour and around that, because it is an important issue about inequality of access. And Judith, could you sort of provide a little bit of additional information or commentary about where the trust is now and where it hopes to be working with partners and, across the ICS? Thank you.
Thank you very much, Chris. So I'll just, do you want to come in at the end, and I'll just come back in at the end. I'll just bring Chris in and Melanie, and then I'll perhaps get you to round off. So Chris Oakes, please.
Yeah, I just wanted to emphasise that as governors have very kindly highlighted, we have made some good progress. I think we get positive feedback in the culture, but I think equally it's really, really important that we say we have a real passion around this within the exec team, within the organisation, myself as the exec director lead. Whilst we've made good progress and good progress compared to others, that's no thought that we would rest on our laurels. We have a real passion to get to where we need to, and we don't think we're there yet, even if we've made some good progress. And I can probably answer the question on the staff survey. There are indicators within the staff survey, in particular around the workforce race equality standard and the workforce disability equality standard, which we pull out and which we look at with other indicators. So we do have very clear indicators that we look at our measures. We have made progress on some of those. I think in the latest survey on a few we may have dipped back. So it's something that you've got to constantly monitor and work on. And we do take the feedback. So for example, on reasonable adjustments, that was fed back in the staff survey, and we've done a lot of work around that, which our disabled colleagues and our staff with long-term conditions in the network have worked and co-produced with us and have fed back really positively on. So I hope that we, that's certainly our intent, and I think we do demonstrate that it's a co-produced process that we loop back and look at the indicators and desire to move even further forward.
Thank you, Chris. So I think hopefully, Helen, that answers your question, but we can perhaps highlight when we loop round with the staff survey results, we can highlight what that's telling us. It refreshes, it's another opportunity to refresh where we are, which is really what Chris has said, but it's very, very much a core element of the staff survey, along with the other sort of aspects of the people promise that we can update you on when we come back round that particular loop. Melanie.
Hi, yes, morning everybody. Well, I mean, there's so much to say on this topic, isn't there? But I just wanted to pull out one particular area that I thought governors might be interested in, and particularly following up on David's comments around language. One thing that I see NHFT and LPT, and where the group model has been a great success, has been a focus on enabling people with protected characteristics and generally to to shine a light on equality, diversity, the impact, is the amount of focus we put on people being able to tell their stories. And I've been lucky enough over the last month or so to attend a number of events laid on by NHFT and LPT around transgender, around equality from a race perspective, where people have come on and been able to really talk about their own experience, their own perspective. And when it comes to trying to tackle this, there is nothing that's more important than really listening to people's experience, understanding the impact that you as an individual might have had unintentionally, or you know, clearly there is some that is intentional. And I think that that is just something that NHFT in particular is doing particularly well. And so I think that's a particular area that I wanted to celebrate.
Thank you, Melanie. And it's so important, isn't it? It's a really important way of developing our own understanding, because I think, you know, colleagues who've been part of the organisation for a while will remember that reverse mentoring was something that the executive team undertook, started to do quite a few years ago. And I always remember how powerful that was as an early intervention. I remember sitting and listening to exec colleagues talking to the CQC, indeed, when in fact we were being inspected at the time, about the power of that experience. And that was very much hearing from people about their experiences, and then, you know, using that in a positive and constructive way to say, well, what does that mean we need to do differently? So I think somebody said it earlier, the lived experiences of people and hearing people's stories are really important, and the data is important, and it's bringing those things together and kind of looking at what is that telling us always. So really powerful. Thank you. You did. Do you want to, I think Chris made a comment, Chris Davison made the comment about the baseline, I think you did, around inequalities and, you know, inequalities in access particularly. Is that something you are able to say anything about, or I don't know if Dave Mayer can comment on it. It might be very specific within the EDS objectives, but I just don't know if you want to comment on that, or is that something we need to take away?
I think I need to take that away. But I've got a couple of comments with regards to Helen, and I know that Banu wants to come back in. So I'll just quickly round back to Helen just to sort of finish her question off. I totally support what Chris says in relation to the staff survey, but also please rest assured the NEDs do actually triangulate the staff survey responses with the equality reports as necessary. I mean, I certainly do, and it is something that I, you know, sort of, that's part of what I see as my role. But also, you know, there are the service visits where I always sort of try to be, you know, ensure that I speak to a wide range of staff and try to get some staff stories, which I then sort of, you know, feed back to the NED group. And finally, it's the NEDs engaging with the staff group. So going to a REACH meeting and just listening, just really listening to what staff are saying and asking just pertinent questions, and maybe following up with somebody outside the meeting. That is all. So all these other aspects are areas where I would also definitely gain assurance from. And Chris, too, just, I mean, the observation I have in relation to the baseline, I don't have an answer for you, but one of the things that is being currently worked on and discussed at system level is this whole the equality of access for everybody. And it's something that I know that we discussed only earlier this week, because the NEDs attended a system-wide NED meeting to discuss the ICB and the ICP strategy. So it's not something that we're going to lose sight of, but, you know, apologies, I don't have a specific answer for your baseline question.
Thank you, Judith. Banu?
Thanks, Krishni. And I was just about to come in on Chris's question as well. In that, from the perinatal point of view, say I work for the perinatal team. And nationally, the driver now is to ensure that there's equitable access. In some ways, our kind of the team, because we are a more kind of in a way a smaller team, I think we're able to focus on it. So for in some the numbers are, say for example, depression in women in kind of in the postpartum period is about 10 to 15%. The OCD at other times is 1%. Here it's 2.5 to 3%. So for the proportion of births that we have, for the 10,000 women we are seeing, we expect to see a certain number of people, certain number of women with depression. And we are not seeing that many in the sense. So there is that access, there is that in some ways BME kind of gap access. So now what we have done is, as part of it, is kind of first make sure that we have got the data in kind of the population data, and then making sure we are seeing that number of moms with those conditions. Otherwise, it shows that we are missing somewhere. So there are kind of, because it's almost one of these recent drivers in the long-term plan. And I think kind of we have just started, and I know there is kind of quite a lot of work to be done on it. I would really appreciate if Judith can come to one of our team meetings, or maybe just kind of share what others are doing and we can learn from it. But I think we're hoping kind of in 12, 18 months, by once we collect the data and then work out what we are seeing, we will probably be able to know where we are missing that group. And I completely agree that it is, unless you have that baseline data, it's very important to know kind of the right steps. Thank you.
Thank you, Banu. Thank you. I mean, clearly, it's a very sort of, it's something we need to look at on a service by service basis, really, isn't it? Is what would we expect to see? You know, it's in that broader sense. I do remember, I think, when we were talking previously about waiting lists within ADHD, and I think we were talking about equality of access. I seem to remember Melanie raising a question about that within a board session that we were having, because it's a constant theme. It needs now to be a constant theme. Or are all the people who really need to access our services, are they, you know, is the profile of our services as representative as we would expect it to be? So it's an ongoing challenge. I think Judith's right to highlight that this is something we need to work together within the ICB across the system, and it's not something we would do just on our own. But we will take that away as well, Chris, in response to your question, and just see whether there's any more that we can say about that. Thank you very much, Judith, for your presentation. I think that was really, really helpful, and allowed us to shine a light on this really important area. As others have already said, we'll loop back round on what the staff survey says about the EDI perspective as well when we come to present that at the next meeting. Chris, final comment?
Yes, thank you for allowing me to come back on this, and rather than just a theoretical data set issue, I wanted to bring this to life with a really practical example. You're absolutely right, Krishni. It does at some point need to think about, well, what is happening for certain services. So if I may bring an example to bring this to life, on Monday we had an NHFT members event where we had an excellent presentation from Lindsay Burgess about the diabetes pathway, and there was a lot to applaud, a lot to admire about the work that goes on from the team. But when you look at the population growth in Northamptonshire, which has grown to about 785,000, there was a representative, a member from Northamptonshire Sport, who was saying, when I'm in these events, putting on, programs to support people, particularly from the Southeastern Asian heritage, their first question is diabetes, and they don't know where to go or how to access. And that's not a criticism. It's just trying to bring to life the issues that people from ethnically diverse groups have in terms of accessing not just mental health, but physical health services, where we know there is a higher prevalence of illness and disease in the Southeastern Asian community. So I just, while people were talking, it came to mind while we were having that discussion, and I just thought that might bring to life that this is an issue particularly about how we look at access, particularly for those ethnically diverse groups where we know there is a higher prevalence of illness and disease. Diabetes was one of them. Thank you.
Thank you, Chris, and really good to link that to the live example of the webinar that took place earlier in the week. So thank you, everybody, for the comments. I think that it is really important to highlight inequalities in access, and we need to, you know, it's clearly a priority for us within the ICB and the ICS. So we will continue to work with partners in that context. I think we've now covered much of the sort of early part of our agenda, and I'm in the luxurious position of being able to give us a break, which I'm sure would be very welcome before we start with our next item, which is item 9, which is Mark Majors very kindly going to talk to us about his role as a partner governor in the context of Northamptonshire carers. So if we can reconvene at say in 10 minutes. So grab a cup of tea or a cup of coffee, and we'll see you in 10 minutes if we can start promptly, let's say at 11:37. I think we can make a good progress through the agenda. So see you shortly. Please remember to turn your camera and your microphone off if you're leaving yourself linked in. Just give everyone a minute to make a start. Mark, are you ready to go in a mo?
Yes, thanks, Krishna. I think Tracy's going to share some slides for me.
Okay.
Oh, great. Thank you, Tracy.
Okay, so welcome back, everybody. As I mentioned before we paused for a break, we've got our partner governor story now. If you remember, many of you will remember that we did some staff governor stories, which we thought were really helpful in bringing to life the roles of staff governors within NHFT's Council of Governors. And we then agreed that we would welcome the opportunity to hear from partner governors, many of whom have worked with us for a while, and particularly because they obviously play a slightly different role because they're employees and representatives of the partners that we've invited to be part of the council. And Mark plays the very important role of being part of Northamptonshire Carers, and so delighted that I can hand over to Mark Major.
Thank you very much. Hello, everybody. I think I've got 2 tasks this morning. I think the first one is to talk fast, and the second one is to try and be interesting. So I'm very confident on the first part, and I'll leave you to judge how well I do on the second part. So could I have the next slide, Tracy, please? So just to talk about how important I think that the partner governor role is, and probably to start by saying I think it's a two-way street, really, because I think it's very good for kind of NHFT in general and COG to have those kind of external perspectives of you know, be they topic specialisms or be they kind of connections to other sets of services or cohorts of people out in the community. And to the voluntary sector as well, but I also think it's really rewarding from a governor point of view, and so I'd say that I get a lot out of that role, and I really enjoy doing that role as well. So, for instance, we had a really good meeting yesterday. Some of the people that are on this call and some others about ways that we can look at supporting carers better within NHFT and the wider community as well. So there's some really good practical spin-offs from that kind of partner governor role. I think another thing that I've always liked about NHFT is around the ethos. It's how it's led and what it stands for, and particularly that mindset of continuous improvement, which I think is really important to be confident of from a care and patient point of view. And then, of course, the other really rewarding thing as a governor is to see the excellent work of frontline staff as well. And you know, the NHS has been a shining star through a very difficult set of circumstances for the country, and actually the frontline staff have been the biggest shining stars of all. So yeah, so there's something, and I've just listed the kind of other things that I do or I'm involved in there. So there's definitely something about the linking of those worlds into COG and into NHFT in general. So next slide, please, Tracy. Okay, well, if we were on Mastermind, we'd be on to my specialist subject round now. So just to give you a few headlines, because I think it's really important to have that line of sight around carers. So in Northamptonshire, there's over 60,000 adult and young carers. That kind of roughly plays out to a tenth of the population looking after more than another tenth, because for those of you that are carers, you'll know this already, but sometimes you're looking after more than one person. Could be elderly parents, could be an elderly parent, and you know, a child with a disability or long-term health condition. What the census data told us, and it's got a bit of a health warning with it, the census data, because it was done during the pandemic. So we saw a drop off in the number of people that were caring up to 15 hours, but this could have been because of restrictions and things like that. However, what we saw was really big increases in all the other categories, and particularly there were many more people caring for over 50 hours per week as well. So the next part is I suppose just around the extent to which carers underpin health and social care in general. So Carers UK do an annual piece of research where they calculate the number of replacement hours that would need to be put in for what carers do, and then they cost that against an average regulated care cost. That sum of money last year was £134 billion. So that, you know, in Northamptonshire, we've got that rough matrix that we divide everything by 100 because of the population size. So that equates to £1.34 billion in Northamptonshire. So just to give you some sort of perspective there, that national figure, the 134 billion, would be the approximate cost of a second NHS. So when we're thinking about who carers are and what they do from a systems view, we've also got issues to consider about carers' own health and well-being. So all the national research tells us that carers are twice as likely to be ill as the general population, and are at a greater risk of depression and anxiety. I think there's something for us as a kind of a trust to kind of think about also carers when we're talking in terms of general mental health and well-being as well. So when you kind of think about that, whether it's the 134 billion nationally or the 1.34 billion locally, there's something for me about it. If as a system, you know, we don't invest properly in carers support, you know, the group of people that we're relying on within this system are a group of people that are an at-risk health group themselves, then really any assumptions that we've got about outcomes for patients and service users, and any assumptions we've got about overall system costs could be blown out of the water, because if you get significant tipping into crisis in this group of people, it's going to completely overwhelm your system and your system costs. And then the other one, and we all know this already, but we're in a very challenging period around demographics as well. So we know, for instance, in the country in general, and this is a bit more exacerbated in Northamptonshire, but it's the percentage of people that are over 65, 75, 85, etc. We know that we've got more long-term health conditions, and we also know that we've got more things like dementia as well. So really, you could take all those numbers and number crunch them, but really that comes down to, from a carer's point of view, more people looking after more people for more years. Next slide, please, Tracy. So this is the kind of carer support model at an ICS level. As you can see, the really positive thing is that there's so much there, and so we've got a lot to be proud of in Northamptonshire. This model won a Health Service Journal Award last year, and we're so proud of all the organisations who work together and all the staff involved that kind of went into that. And so that thing around a model of good practice nationally, I think is really something to be proud of in Northamptonshire. So what are the key ingredients that have kind of got us to that point? Well, there's definitely something around effective partnerships. There's definitely something around integrated approaches. There's definitely something around statutory and voluntary sector collaborations, and there's definitely something around listening to carers and those they look after, and co-production. There's kind of like a point that I'd make, which is when we listen to people about what they need, and we involve them in developing and delivering services, we tend to get things right as a system. When we don't, we tend to get things wrong. It's not really rocket science, but it's a it's a fact. All of those things said, of course, it's absolutely not a case of resting on laurels, and there's so much more to be done. I think what we're seeing frontline wise at the moment is not surprising, because some of these are kind of system issues as well. But the kind of combination of caring roles already being things that are under a lot of pressure, and the fact that people are doing them for often long amounts of times or in very difficult circumstances, when you combine that with the underlying things about carers' own health issues, you then throw in the effects of the pandemic, both in terms of social isolation for people, but also from the fact that really a lot of people that with long-term health conditions, those will not have improved during the pandemic. In fact, they will have got worse. And then we've got the huge challenges of a system of trying to unlock some of those things in the demand for services as well. And then just to kind of throw in the kind of cost of living issues as well. You've kind of got a set of things there that are, we're seeing more complex need and more people in crisis. So that's something for us to focus on, and that's a key area that we'll be focusing on in the first year of carers strategy delivery for the county as well. There's a lot on this slide we've circulated, so just I'm really happy to have any conversations with anybody at all separately around any particular parts of this that they might be interested in. So yeah, and so the last part, and I think this has been something that has happened in the other kind of staff stories and kind of governor stories as well, which is around kind of what's most satisfying and most challenging. So I'll start with the most challenging so that I can finish on a high. I think it's still that thing that I know we all share, that although we're doing an awful lot of good things, we're still seeing people in the system that are getting poor outcomes. And so what can we do about that? And the world of ICS gives us some really good opportunities around that set of things, and working together around them. I think something that's really challenging and is really challenging at the moment is kind of, and I suppose it comes back to where ICSs are compared to where ICSs need to get to. And this is around kind of hand-to-mouth funding for the voluntary sector as well, and the effects that has on patients and carers. I think there's something that we have to be really careful of within the ICS, but it also links to representation as well. So the voluntary sector being an equal partner within things, including decision making within the system, and that patients and carers and service users are cited and involved in what we're doing and the changes that we've made. And I'd say really the last 3 or 4 years as for me been almost like a good practice guide of what those sort of things should look like, but the last 2 months have not been. And so I think that there's some challenges around how decisions are made, who's making them, and have we got the right people around the table in terms of making those decisions? Because I firmly believe if you haven't got the right people around the table, you don't know what all your opportunities are in terms of what you can do as well. So there's some of the challenges in terms of what's most satisfying. Well, absolutely, it's that thing around it. It's so humbling to support carers with what they do as well. I'm always reminded of that phrase that sometimes the very worst of circumstances can bring out the very best in people, and it's really humbling and awe-inspiring to kind of work with carers and see what they do. Obviously, it's incredibly rewarding for all of us that are involved in working with carers around being able to make a difference to them and what they do. It's really great that we've got things between us all as a system and partner organisations into having a good set of services and being seen as good practice, but there's obviously always more to do on that, and it links back to that point that I was saying. One of the things I've always admired about NHFT is that mindset of continuous improvement, and we hope that we kind of mirror that in what we try to do. And it's also that effective partnerships and co-production piece as well. I think that when you're working in that way and you're working with other people, it's not only the system that gains a lot, but organisations gain a lot, and individuals within that gain a lot as well. So I'm a huge fan of kind of collaboratives, partnerships, and kind of effective working together. So yeah, that's it. I haven't done too badly on the being quick part. So yeah, just if anybody, happy to take any questions if we've got time.
Thank you very much, Mark. Really, really helpful insight into your role, and then kind of particularly the support and the importance of carers, I think, and the importance of carers' well-being as well, and thinking about how we make that integral to the way we work. And it's worth saying, I think, that Mark has certainly supported us in as a trust in making sure we have trying to make sure we have an effective working carers network. So recognising that some of our staff have caring responsibilities and how we support people to do that. So I think that's been really important as well for us, because a lot of people don't recognise that they're carers, and then what support they can access has been really important. So That's a really key point. Okay, so I know there are a few comments and questions. So first of all, Julia, please.
Christian, apologies, Mark. I didn't mean to put my hand up halfway through your presentation, but once it was up, I thought I'd leave it there.
No,
Hope I didn't put you off. Just reflecting, that was a really, really brilliant presentation, because you've just distilled it all down for me into the real essence of what being a carer is about, and actually how important all carers are to just about every part of our lives generally. I talk about us as sort of a population. You just used 2 words about humbling and inspiring, and I actually felt that applies to you. You bring such a different perspective for us in the Council of Governors, and I think you're a really, really important advocate for, as others have said, Melanie said, for often an invisible group of people. So thank you for that from the bottom of my heart, really. And just to say, system-wise, I think you give me hope. I wrote down hope as you were talking, because the system's got a lot to look at. We've got a lot of priorities, and there's a lot of competing groups of people, and you give me hope that actually we can all now really understand what's needed, and I think we will absolutely be, all of us need to be advocates. And yeah, I just want to leave you with that thought that you give me hope.
Thanks a lot, Julia. That's really kind. I mean, Angela will tell you the same thing that I'm going to say as well. And any CEO is only as good as their staff. And luckily, we both got the commonality of having wonderful staff. So you kind of tend to look a bit better because of what other people achieve as well. And I think the thing about hope's really important, isn't it? Because actually, ICSs and kind of work of organisations within that should absolutely be aspirational, shouldn't it? It's about getting the best set of services that we can for our different communities.
Thank you, Julia, and thank you, Mark. So Melanie next.
Yeah, I've got 2 things really. First of all, just internally within NHFT, I sponsor, lead, and am a member of the Working Carers Network. And I think, again, it's another great example of how listening to the challenges that staff have and understanding the perspective of what it's like to work and be a carer has been particularly important and informative. And Mark, I know your team have been a keen supporter of that network, and we connect up with you both within that network, but also in the production of the carer strategy that the Trust works to, and has support from your organisation in so many ways. And it's another good example of that partnership, isn't it? And an integrated approach. I also, because I put it in the chat, but I feel so passionately about it, I felt I ought to, I thought I'm going to grab the mic and just draw some attention to it. I think it is absolutely critical, because I do think that a high number of carers, and Mark, I wouldn't even begin to know whether it's a minority or even a majority percentage, but there's an assumption, I think, sometimes that carers are mapped to patients, and therefore that they are seen and visible and participate in healthcare discussions. But I think there's a large number of carers for whom there is very little contact with the NHS. The condition of their caree, or whatever the term is for the person reserving care, is such that they don't have routine, frequent appointments, and therefore the carer is largely invisible. And that's where I think this whole system is so critical, because it's the connection to local authorities and the social services who actually see the carer probably on a more routine basis. And it's important, therefore, that the ICS strategy, and that there is all of that discussion with the organisations who don't necessarily feel that they're care providers, but they actually have the greater contact and opportunity to support the people whose health will suffer if they're not adequately supported, if that makes sense. So apologies for going on, but
thanks, Melanie. No, there's really good points there. Richard's put a really nice little concise bit into the chat about some of the things we were looking at the meeting yesterday and where we're going to go with things. But you're absolutely right to kind of take us to the place of delivering on the carer strategy work as being the way to I suppose make the bad better and the good great. I suppose that's what it's about, isn't it, really?
Great expression. I like that. Thank you.
Thank you very much, Melanie. And yeah, helpful summary from Richard about the meeting that took place, which, if you remember, was sort of it's quite helpful that I think the last story we had, staff story, was actually from Dr. Krishna Yathiraj, who actually, if you remember, is a passionate advocate of something that he's been instrumental in called Carers Corner, which is about supporting carers of people with mental, our service users who have mental health needs, supporting carers through the work of the trust as well. So it's been great that we've had a kind of two different ways of focusing on the carers' needs, I think. Okay, couple more comments. Joanne, Chris and David in that order, please, and then we'll bring it to a close. So Joanne first.
Yeah, Mark, thank you. Thanks for your key messages. They were just absolutely spot on, not critical, just moving forward, aspirational, and in the right direction. I just want to come back to you about patients who are being cared for by their carers, yeah. And as you know, in the journey of life, in the beginning, when people are born, then parents look after their infants, and then diseases happen and care has to take place at any stage of life. And at any stage of life, then end of life comes. And I just want to highlight and say that I went on a webinar on Saturday called Making Dying Better. And it was 3 national speakers who were talking about, again, having early conversations, talking about DNR forms being in the right place at the right time, and having the right drugs in the syringe driver at the right time at the end. And again, you said that the last 2 months have been very difficult, and you see again situations whereby end of life is chaotic, and I'm just again asking to put that on the table, because that is an area where it's difficult, isn't it? Difficult for everybody. The message is we want people not to be dying in hospital, because we don't want the hospitals flooded by patients who die there, and we want them to support them in the community. But then it's that infrastructure, isn't it, to help support in the community. So I just wanted to share that because of what you'd said. And I felt that gave me the opportunity to just share, if that's okay, Mark. And we had a conversation, didn't we, about a particular patient not so long ago.
Yeah. Well, you like me and other people on the call this morning have got a kind of passion around trying to improve things around end of life care. I think as a system, we know that we're not doing the type of things that we would want to be doing. But back to Julia's point about trying to have hope in the situations, I suppose I'd just throw this out there in the world of integrated care systems. NHFT have nursing staff. Ourselves and other people within the voluntary sector and other providers have regulated care staff. We have carer support workers. For me, this is the classic world of integrated care systems. We should be thinking about not just flagging it up as a problem, but have we got the answer to some of those things collectively as well? And maybe that's something to reflect on and maybe try and go back into the ICS and into the end of life strategy and actually see if there's some partnership ways of working together, because we've certainly seen through the ICAM programme that we've got ways that we can work together and blend those things and actually come up with a really good set of services as a result.
Thank you, Mark. I'm really conscious, actually, we are now beginning to run over time quite significantly, and there's a danger that we're actually going to eat into the time that governors have to contribute to the discussion about the plans for 23-24. Chris, can I ask you to make a very brief comment and then we can close this item? Is that okay?
Yes, thank you. Just as briefly as I can, Mark, thank you. Thank you, you're still here. I was reflecting just before pandemic when we last met. You and Sue gave a talk about the work you do. Your presence is much appreciated. And just to amplify your point, as others have made about the invisibility of carers, I think the estimate of 50,000 is too low, as you know. I was at an event last year where a couple in probably their late 60s came to a meeting. They wanted to know if there was any help because the wife, as in the daughter, who was profoundly deaf, was caring for her mother in the 90s, who had dementia, and they didn't know where to go. And I was working with John Quirk, one of your team, and was able to bring the two together and to use the phrase that's been used before. It's about hope, but we mustn't underestimate the unmet need that still exists, both in terms of young and adult carers. But thank you, and your award is due and just recognition for all that you and the team do within health and social care. Thank you.
Thank you,
Thanks
Chris.
very much, Chris.
And Mark, thank you so much. I think this has another shone a light on a very, very important topic, as Chris has said, and an important group that we all have a responsibility to consider in terms of our support and care. And just worth highlighting that because obviously Joanne mentioned earlier about the end of life support for people at the end of life. Jean has made a comment that the ICB has recently drafted a strategy to improve end-of-life care with a clear implementation plan. So hopefully that is an area where we can demonstrate some improvement working collectively. So thank you so much, Mark. Really great insight as ever, and really good to hear your experiences, and no doubt something we're going to come back to in future discussions as well. I'm going to now hand over to David Williams. David, I can't see you on screen. Oh, yes, there you are.
There we go.
You are visible. So David, over to you. You've got pretty much, I think, most of the rest of the session to run a session on our plans for 23-24.
Lovely, thank you. So welcome everybody. David Williams, so Director of Strategy and Partnerships. I'm going to hand over very quickly now to David Mayer, who's going to take us through an introduction around the annual plan and the way it all connects together in a system. And then James Mullins is going to take us through an understanding and a conversation about quality priorities. And then we're coming back to me to give you a bit more of an update about DigbyQ and some conversations around inequalities, our priorities and ways of working. And I think we'll do that to try and look to finish by about 12:50, I think, for AOB and other things, if that's okay. So David, over to you.
Thanks, David. Hello, colleagues, and hello to new trust members and others joining. And great to see Mark have a slot on this, and send big congrats again to him for his award last year. Well justified, as people have said. So I'm just going to take us back a little bit to the story of the annual planning and where it's taken us to over the past decade, just over the next kind of 7-8 minutes. So since 2020, we've had obviously historical rates of increase in cardiac support, and mortality increased, outcomes improved generally, and we saw waiting lists begin to improve massively, which took us up to the second most recent policy guidance around the 5-year forward view, which was published in 2014. And that heralded a massive increase in mental health services and a huge emphasis on primary care investment and community services improvement. That 5-year forward view was then succeeded by a long-term plan in 2019, which set out some big ambitions around prevention, big ambitions around inequalities, a greater focus on frailty, and for the first time, a bigger recognition of the NHS as an anchor organisation in communities. And I know we'll be coming back to anchor discussions. We've had some of them previously with KGH and others. We'll be coming back to some more of those in due course over the coming year, I'm sure. So where we're up to now, post-COVID, of course, and the long-term plan did set this out, that we would herald the integration of integrated care systems, which would succeed clinical commissioning groups. The Northamptonshire one, along with the rest in the country, formed on a statutory footing on July the 1st last year, and they now have been issued in December with a set of guidance materials to spec out what they need to do over the coming year, this financial year coming, and then the next 5 years, which is a 5-year forward view as an integrated care system. So how we're approaching this in NHFT is, one, we have to submit an operating plan to our regulators detailing how we're going to deliver on specific items within the long-term plan. So those things that may have slipped during COVID because some of those ambitions had to be shelved as we dealt with that pandemic. So we've missed 3 years. So there's a bit now about resetting, about how we get back onto a level footing for the next few years, the next coming year, and certainly for the next 5 years. For NHFT, we're going to embed that operating plan in an annual plan, similar to what we did last year. And we'll be hanging that plan off DIGBQ, our strategy. So it'll be an overarching framework for DIGBQ, so that's delivery, innovation, growth, build, and quality, for those not familiar with some of these acronyms. We'll also begin to integrate the 5-year priorities for the ICB, and we'll begin to take a firmer look at the NHS long-term plan priorities as they were set out previously. And bearing in mind that most systems developed a comprehensive long-term plan in 2019. So there is stuff that we have done which was really, really good. So we are not starting from scratch. And I just want to make that really clear to people. This is not a revolution. It's an evolution of plans that have gone before, albeit in a very constrained financial and very pressured time in terms of services and pressure on staff. So 3 priorities: recovery, productivity, the long-term plan. We'll be making sure that community mental health and learning disabilities are at the centre of the design. They weren't part necessarily of the operational plan submission in totality, but we're making sure they're firmly bedded into our annual plan. It sits then within the integrated care partnership strategy. So that is the 2 local authorities coming together with the ICS partners to enshrine a strategy that covers the county, and that was published about a month ago. So that's already in circulation and is available on their website. And then we'll be making sure that the delivery of this is placed within a delivery framework. We'll be monitoring that monthly through the Exec Management Board, and in due course we'll come back, of course, to governors to give you an update to let you know on how we're getting on with delivery of that. So next slide, please, Tracy. So as I said at the start, so the arc of the story is a positive one for the NHS, with increase in funding since 2000, leading to unparalleled investment in mental health services, right through to a recognition that inequalities are some of the biggest drivers of our health need, as Chris said in his statements earlier. So taking all of that as knowing, how do we now manage the current mismatch in capacity and the existing and emerging need that we are seeing in our community? So as an example, our eating disorder need has almost doubled over the course of the pandemic. So there are numerous examples of those kind of need popping up that we don't have the commissioned resources to deliver. So we have to find creative ways of managing that need and working with partners to mitigate it. An ageing population, frailty was a feature of the 5-year forward view, and it features again in the long-term plan, it features again in this plan. And that for us is about adding years to life and life to years. And Mark talked about the ICANN programme, which did much of that, and we're proud to be a kind of a leading partner in that. I've talked about the increase in complexity as a major risk for us and a challenge in terms of supply outstripping our funded resources. We've got a big focus on morale within teams to keep people, managing their burnout and the pressure that they're under. And then we've got big opportunities in community services through integrated work with our local authorities by bringing services closer together, like we've done with our specialist care centres and recovery independence beds. So we're going to, in the breakout session, talk a little bit about the opportunities. Huge opportunities, we think, in integration across pathways. And we know this from the collaborative work we've done, we know it from the crisis work we've done, and we know it now from some of the integrated bed model work that we've done on discharge, which Jean and team have been leading with our local authorities. There would be a big focus on place. So 2 new local authority footprints, and we will want to make sure co-production and patient voice is at the heart of that. There's another opportunity to reshape the narrative on left shift and left shift to left shift, so that we really do truly bring prevention to the front of our service models, and we think anticipatorily about the needs of our community so we can get ahead of their priorities. Innovation in pathways, I've talked about. Personal health budgets feature again this year for us and for the ICS. Equally, physical health checks across learning disability and SMI will be critically important to some very inequalities work, and a huge opportunity. If the funding follows, they have chipped away at it to meet some of the current funding pressures, but there was, in the long-term plan, significant resources for innovation in digital that has been slightly altered by some of that resource being earmarked to manage service pressures, but we will continue to strive for what good looks like in our digital realm of working. So James, I think I'm going to ask you to come in now on the quality priorities, and we've got a Slido session as well, which people have the link to in the chat, I think.
Yeah, absolutely. Thank you, David, and thank you for everyone. So I'm just going to very quickly take us through a bit of background and then engage a little bit in terms of the shortlisted quality priorities for next year, which I'm going to then ask everyone to put a vote on their top 4 priorities they see for us as an organisation. So just very quick, sort of briefly why we're doing this. We do this every year. Trust publishes its quality accounts. It's a report about the quality of our services offered by us. All NHS trusts do this under the Health and Social Care Act. And it's, as I said, it's how we provide that assurance around quality within the organisation. So what we need to do is we need to decide on at least 3 quality priorities. As an organisation, we have decided to take 4 quality priorities. And the way we've sort of arrived at the shortlist of the 6 that we've come to, these have come through discussions with senior execs, with senior colleagues, and other, sort of groups throughout the organisation, Quality Forum, etc. What we've once we've got the 4 themes agreed, what we'd do is then work them into priorities with quarterly deliverables as well. So I just want to run through each of the 6 priorities. You can obviously see them on the screen in front of you, but I'll just give a little bit more background. So the first one is reducing violence and aggression towards staff. So this is a continuation of a 2-year priority, and it's been about what we've been doing is scoping an exercise and a thematic review to understand the problem, and a QI project around ensuring that staff feel safe from violence aggression on the inpatient wards predominantly. The key areas we'll be looking at to improve is the systems of reporting incidents and violence and assaults to staff within the trust, and how the police are also involved in implementing a feedback process as well for staff who do report who are involved in those situations. So reducing the incidence of assault and improving the feeling of safety for staff and patients is the overall aim. The second one is using quality improvement to improve patient safety and experience with regards to pressure ulcer care and treatment. And this is a key area for us as an organisation. Pressure ulcers is the highest reported incident that we have on an ongoing basis from a patient safety perspective and a quality perspective. So what we're proposing is using QI techniques to improve patient safety and experience with regards to pressure ulcer care and treatment. As I said, pressure ulcers are increasing month on month, so we'll be looking to investigate the reasons for that, implement strategies and techniques to decrease the number of pressure ulcers, and lead through the newly set up NHFT Pressure Ulcer Group, which will be chaired by Richard Amponza, who's our Assistant Director of Patient Safety. And it will also feed into the Strategic Pressure Ulcer Group that I chair with LPT and the NHFT Patient Safety Committee. The third one is to establish and implement and embed heat maps as part of the board toward oversight of trust, quality and safety. And this has come as a recommendation from the recent quality and safety review that was carried out at the end of last year, and that Chris mentioned at the very beginning of this meeting. And this would give us that opportunity to bring together all the intelligence around performance, safety, quality. It's available in the trust into one usable, accessible data visualization tool. The fourth one is implementation of the patient safety incident response framework. And this is part of not only the national patient safety strategy, it's also part of our NHFT patient safety strategy as well, to introduce the framework, which for shorthand is called PSIRF. It's a really important step for us as an organisation in terms of how we look at, how we learn from patient safety incidents, not only within the organisation, but across the system as well, and with other partners too. The fifth one is a rollout of the EMPA to specialist palliative care and community bedded inpatient areas, and then scoping the functionality of the Civica system for use in community mental health teams. And this is a priority with regards, obviously, pharmacy and medicines management. Like I said, two parts of this one. Firstly, it's about the electronic medicines prescribing administration, which is EPMA, into specialist palliative care and those community bedded inpatient areas. And what it does is it improves the legibility of prescription, provides decision support to offer safer prescribing as well. The second bit of this, sorry, emails keep popping up. Look at the priority, scoping the functionality for use in the community mental health teams as well, with a view to prescribing and administering depot medications using the EPMA system. The final one is development and implementation of the Moving Ahead project of the MHLDA Equality Strategy, and a really important step, this one as well, given some of the really useful conversations that were led by Yuda earlier. So this is about looking at systematically addressing unwarranted disparities in mental health access, including patient experience and outcomes for ethnic minority communities in Northamptonshire. So if we can move on to the next slide, if that's okay, what we will be looking then to do is using the Slido to choose your top 4 quality priorities, and they will then feed into the wider engagement that we're doing around the trust quality priorities, with the final priorities being taken then to Quality and Safety Committee in April and SEB in April as well.
Slido is now open. I'll leave the details up for a second and then I'll move onto the screen, which should show the live results. I'm presuming everyone can see this, so just get everyone a chance to log in to Slido, and then I'll move on. I can see people joining.
Pest control.
James, is it worth clarifying? Clearly, these are things that will remain priorities irrespective to some degree of the selection we make today. But I think there's something here about, I believe these are the things we will report in our quality accounts specifically. Is that right?
They are, yeah, it's absolutely, Krishna, it's something I was going to say actually, was around these. These are what we'll report in the quality account, but they're certainly not the only quality priorities within the organisation. There's several of those that are being worked on at various different levels through reporting to various different committees around a number of areas. These are just what we will be looking to, as you said, report on in the quality account.
Yeah, thank you, James. So it's really important to say you're not saying don't do any of these things. We're just saying that the ones that we choose will particularly feature in our quality accounts as our sort of priorities for reporting within that account.
Yeah, absolutely.
Pest control.
I think we're starting to see the themes emerging.
Krishni, I noticed that Helen has asked a good question in the chat. I don't know if you want to pick that one up as well.
I sort of thought I'd address that really, that actually these are things we're going to do, but then the specific for will be reported as part of the quality account. I think that's right, isn't it?
It is.
Cool. So Tracy, it looks like 17 people have put their thoughts through, and we haven't got anybody actively ranking at the moment. So James, you're going to pick up that feedback, feed it into the conversations and the engagement that are happening across with other stakeholders as well. Yes. And then that will come back to us as the things that will go into the quality account as we've talked about. But I would expect that we'll see all of those things kind of in our annual planning as ways of working stuff through and being picked up by teams across NHFT.
Yeah, absolutely, David.
Bro, okay, thank you. So shall we go on, Tracy, to the next slide, if that's okay? So we were going to take just the remaining part of the time to put a little bit more information around DigbyQ, our strategy, explain a bit more of where that goes, look at inequalities, and then look at the things we want to prioritise. And seek some thoughts around it. So as a reminder, DigbyQ is our short abbreviated version of our strategy. So it's about developing in partnership, innovating to improve quality, growing our staff capability, building a sustainable organisation, and quality and safety at the foundation of everything we do. And because everybody shortens everything, we call it DigbyQ because it's a useful way of reminding and thinking about where it is. The real important bit about strategy is that we have a vision, which is to be a leading provider of outstanding compassionate care. And our strategy is taking us from where we are now to that vision. And what we started to do is to set out the tasks and the ways of working and the things that we've got. And actually, we're going to touch on some stuff that I think links very well to Mark's presentation and our earlier conversations. So that's DigbyQ and our strategy. Tracy, if we go on to the next slide. Before we get into the different bits around the DIGB and Q, what we did want to say is that we know that our vision will only succeed if we reduce inequalities, because you aren't going to be an outstanding provider of compassionate care if you can't make a difference to the inequalities that exist within Northamptonshire. And I did think it was worth just taking a moment for that first sentence on the top in the black text there, just to say NHS England are really clear and we would support it. Health inequalities are avoidable, they are unjust, and they are unfair differences in health status and determinants between groups of people due to demographic, socioeconomic, geographical and other factors. And actually in all of our plans and the work we've been doing, Dave talked earlier today about the anchor institutions and the ways we're going. And we just wanted to take a moment to say, if we look at why we collaborate and the things we do, how we use technology differently, how we support our people to develop and do things differently, new roles, new people, and how we deliver outcomes and pathways, everything through there does have a focus around how does it make a difference to inequalities? And also, what more can we do around social value? How do we support and grow our communities? How do we build income in our communities? How do we support and develop with our partners? So we wanted to take a moment today just to be really specific around the fact that there is a focus around inequalities. What we've got for a question now, if we, does it work? There we go, thank you. What we'd like and welcome from you is the first word that comes to mind when you think about the success that we could have in reducing health inequalities. And you should find Slido live now. So I'll give you a moment to pop that in.
We'll just wait till we've got a few people on and then I'll move to the live
Okay.
Thank you. Looks like we've got a large number of people there and nobody typing in at the moment. So thank you very much. You have a word cloud in front of you with the kind of keywords and things coming through. So that's been incredibly helpful. What I wasn't going to do today was now start exploring all of the words and the way of taking things through. We will share these with you and they will feed into our planning meetings, which are actually happening tomorrow. But I'm conscious that if I spend time exploring this one with you now, that we'll probably use the next 20 minutes up of time, and actually there's some more opportunities for you to talk some stuff through. Tracy, could we go on to the second Slido question then? So what's holding us back from achieving success? What's holding the NHS back from achieving success? And I think your views on that would be really helpful to help inform the planning meeting that we'll go on to tomorrow. Lovely. I will just keep letting those participants type and then we'll move on to the next one. We'll give them a moment. Thank you. Well, thank you. Let's just hold on to silos as the key big word and some other things in there as we. Tracy, are you okay to move us on one slide? And for anybody still typing, don't worry, you can still type onto the poll. It's just it doesn't appear on the screen and we'll still capture it. So we wanted to spend just a moment about, and then we're going to come to you after some questions around the develop, the innovate, the grow and the build, to say which bits are resonating, which bits do you think we should do more work on and moving things forward. But I thought it might just be worth taking the comment we've just had about silos and talking about our principles around developing partnership and what we're doing. And thank you, Mark, for talking about NHFT being a shining light, because I think the bit I'd like to explore with everybody at this point is collaboration is something that is absolutely focused from an NHFT perspective, whether that's collaborating between local neighbourhoods, working well with GPs, community groups, whether it's about some of the wider work that we're doing at Place, whether it's things we're doing at County with NHS partners and ways of working. There's an unrelenting focus from NHFT about how do we take things forward, what opportunities have we got, how can we change the way we're working with partners. And there are examples of things that we want to achieve this year. We want to continue to develop and improve children and young people. We want to push through a lot of more peer support frameworks and ways of working that I can see that NHFT is pushing. NHFT is encouraging and taking people with us, and hopefully all of that leads to breaking down our silos, changing the way we work. So there's collaboration that we'd like to reflect in our plan in Northamptonshire. It's collaboration that we can do together and partnership working that we do together between ourselves and LPT. And there's work that we do regionally and nationally. And all of that is linked through into how do we develop ourselves and others and make a difference. We wanted to have another focus on new ways of working, building in new pathways, helping things focus through, and leading us then that partnership working to focusing on everybody's recovery, because there is still an awful lot of recovery from COVID that all our communities, places, people and the county need to work through. So there's a brief summary of developing partnership. Tracy, are we okay to go on to innovate? So innovate for us this year means we want to be demonstrating and showing that we're leading with co-production and helping others to use co-production. This isn't something that is fully embedded across the whole of the NHS, and we believe we've got the opportunity to lever and develop and take that forward more. There's a real opportunity for us to innovate and use technology more, including automation. There are processes and things that we still use in a kind of back office function that actually we could automate, and there's more that we can do. We're exploring examples of things like enabling people to do online booking and other ways of working. So we know there's more we can do there. We'd like to build greater links with our universities. So that's University of Northampton, but also to explore things with University of Leicester and others who are supporting us through training, but also a really good opportunity to think about research and how that would lead to championing mental wellbeing, community care and the work of the NHS. And again, I think that takes you through to innovation being a focus on everybody's recovery and ways of working. If we can come on to grow. This year, a real focus on making sure we get our peer support worker framework launched, ways of working. We wanted to take a real focus about the NHS as a career with apprenticeships and support for our people. I thought as an example to illustrate this, it's probably worth saying that actually you can go and find jobs in Northamptonshire where you are paid more than the living wage for warehouse work or other ways of working. But what they don't offer is the opportunity for a career. And so one of the bits we're looking at is how do we support people to come into the NHS, be supported through apprenticeship schemes that will lead to constant development and constant support. So you could take a pathway like coming in as a healthcare support worker or hotel services member of staff, and actually we support you through, gain your care certificate. We could support you into apprenticeships to develop as a nursing assistant into a nurse and so on, and ways of working. So we think there's a real opportunity to focus on that career. Supporting the well-being of all our people is incredibly important to NHFT and a way of working. We'd recognise everything that we need to do post-COVID. It's important about well-being. We've talked and shared messages with staff just over the last week about the importance of compassion. We've touched on it today, but also the importance of reminding every individual to be compassionate about themselves, because you can end up forgetting about yourself at times. So a big focus on how we make sure everything's delivered in compassion, and that should give us the space and the support to recover from the pandemic. So that's grow. And as we come on to build, I think building a sustainable organisation, it's really important for us to review the capacity of services and the new demands for them, and then designing new pathways and new ways of working. We've got an absolute commitment to deliver a green plan for our environmental sustainability and making that work. But we also need to recognise we do need to be as efficient as we can do in everything we're doing. Things like automation, different ways of working can help us do that. But it's important we make the best use of taxpayers' money and we're efficient in everything we're doing. If we can do those things inside our organisation, then what it also does is develop new opportunities and new pathways for a sustainable NHS across Northamptonshire. So there's a very brief introduction for developing partnership, innovate, grow and build. We haven't gone on to do quality because James has talked about the quality priorities just earlier on in today's session. We've now got another Slido question and an opportunity for you to say, please let us know what 2 things have stood out to you as being very important from that summary. Lovely. I'll just give people a few more minutes to just type some stuff in. Tracy, does this make it too complicated if you were able just to pull the line down just so that people can see what else is down there? So that just gives everybody.
Yep.
Yeah, that's worked. That's brilliant. Thank you. Excellent. Thank you. So we'll take these and build them into the work we want to do on the plan and the importance of picking things up. They could also become themes for a greater and a longer discussion and taking things forward in future meetings. I think equally as important, and Tracy, if you're okay to move us on to the next slide, is to think, here are the two things that you thought were incredibly important we need to spend more time out. Are there two things that you think we need to explain more about, two things we need to look at in more detail? And I think that poll should just be opening now.
Libby, are you all right to take a question from Chris? Chris, did you want to come in?
Yep.
Whilst that's going on? Did you want to come in?
Yeah, yeah, I couldn't really put it in the Slido box, David, and I'm sorry to jump into your presentation, but this is my last meeting, so I'm keen to get this over, in the sense that public satisfaction or confidence levels is at an all-time low in the NHS, and I think there's a lot of work that needs to be done to rebuild that trust. And I'm trying to offer this, because I couldn't put it in words, is that the NHS is heavily controlled, managed and regulated, and as governors we have a foot in the NHS, but in the community where we represent, irrespective of our constituency, things are organic, they evolve, they're fluid, and they need to, if you like, evolve, but they're based on relationships, so people have to trust us before they trust our message. And I'm not sure how to convey that, but hopefully you'll get a sense of what I'm trying to say. That we really must be very careful with all the good work that's going on, don't get me wrong, and it needs to be regulated, controlled and managed. But in my view, there's a real, from talking to people, people I represent, the need to rebuild literally trust as an institution, because certainly satisfaction levels has fallen to a 25-year low, certainly since the pandemic in 2020, where levels were high. And I didn't know how to convey that best in a Slido question. And I think that's a bridge that hopefully perhaps governors could be involved in some of that public engagement or at place level. But yeah, ultimately, people have to trust us before they trust our message. And that's really important in the community. Thank you.
Thank you, Chris, and very helpful. And I think partly I felt in the comment you were making, you're touching on some of the points that David raised around his chance meeting on the stairs and the importance of actually how the public understand and know what we're going on. I think you're also touching on some of the stuff that Mark helped raise about working with the voluntary community sector and the ways of moving things forward and working where things are. So I'm an absolute advocate around making sure that everybody is trying to deliver the best services that they possibly can do for the outstanding compassionate care, trust and support each other. It's one of the reasons why I think developing in partnership as a system is an incredibly important piece of way of working. So I suppose in building trust and in making things work, there is always an investment from NHFT in the relationships with many other organisations. And absolutely, you're right. The more that governors and others can do to help people understand the new way of working of the NHS and things, I think it's incredibly important. Lovely. Thank you. Thank you. That's great. That's been really helpful. Tracy, would you be all right just to do a little? I was going to ask you to do a scroll down if that.
Oh, sorry.
That's all right. If that's difficult, there we go. I just thought we'll share back with everybody everything we've got and the ways of working and working things through. Thank you. So go on, yeah, next slide. Thank you. So what I wanted to do here was to spend a little bit of time just talking through the next steps and just talking through where we are and what we're going through. So your feedback helps us review and think about our priorities and ways of working. We've been running and working through kind of weekly planning meetings, engaging with staff and talking to stakeholders. We'll add all of this into tomorrow's meeting and the development and the way forward. And what it'll do is it'll give us a more detailed annual plan with a kind of focus on priorities and ways of working. We'll draft that all up and that will come to the NHFT board for approval at the end of March. And then that sets us up in our way of working forward for the next 12 months. What we end up doing then is working that through so that inside NHFT, in our management team and transformation committee, we will do the updates and the progress and the ways of working through. But on a quarterly basis, we report that in public to the board so that then everybody can see the progress we're making, provide an opportunity for understanding what's there, what isn't, and how things are working things through. But thank you very much for your comments today. I think I've probably whizzed through a little bit quick because I was just conscious of time and trying to make sure we weren't there. So if there's anything that comes up another time, just drop me a message or we'll share some stuff and we'll share the plan with you in the future as well. So thank you very much.
Thank you, David. So I think, you know, really good to see your contributions there. Clearly, David and the team will need to do a bit of work to pull that together. And I think Chris made a really important broader point about how we work together to sort of, you know, build trust in what we're doing, because ultimately, you know, the NHS is a key part of the community. That's what sort of being an anchor institution is, and we need to have collectively, you know, and this is the bit I think David was emphasising, you know, we obviously as NHFT can play our part, but we also need to influence the system and work very closely with our partners across the piece so that we can make a difference collectively to our communities, because one of the words that really was striking was, you know, avoiding silo working and the problems that poses, I think, in one part of your feedback earlier. So thank you so much for that, and you'll see as David said, we'll be taking your feedback and the other work that other colleagues have done to reflect into the plan, and then that will be something you'll see through the course of the year as it gets reported back at our board meetings. Okay, I don't think there's anything else that I particularly needed to cover as part of that. So just to remind you that our board meeting is taking place on the 30th of March. Governors do have the opportunity to observe that meeting and can have access to the papers, and there will be an opportunity, I think Tracy and the team will write out to you about that to ask you to let us know if you'd like to be able to observe the meeting. And as we've already said, we'll loop back round on some of the issues that you've raised in this meeting, like the sort of link between the equality, diversity and inclusion staff survey, because you know, we'll be definitely will be taking that topic at our board in March. So before I close, I'll just bring Joanne in. Joanne?
Just a quick question. With regards to the pressure ulcer work, dietetics isn't involved in pressure ulcer work, and yet we are one of the key interventions when we calculate a patient's nutritional requirements and help them go above and beyond their energy requirements according to their calculated energy and protein. So who does dietetics speak to, you know, make sure we're a partner in that stream of work?
Thank you, Joanne. David, were you coming in to respond to that?
Yeah, I was going to. So I think James has left. He's had to go on to the next meeting. But Joanne, let's connect you and James together to talk it through.
Yeah, thank you.
Okay, lovely. Thank you very much, Joanne. So we've got a few minutes left, and I just really wanted to say again I know a number of governors have had to leave, but we've still got the bulk of you present, and I just really wanted to say, thank you very much for your contributions today. We've covered a lot of ground. It's great that we've done so much of that in public, and you know, always welcome to be able to do that. Secondly, to yet again kind of recognise, you know, the governors for whom this is the last meeting, the last formal meeting. We absolutely will be engaging with you over the next few weeks on anything that we you know, on some of the other discussions that are undoubtedly going to continue in the background until people's terms come to an end. So I just really wanted to recognise again and thank all the governors, Chris, Helen, too many to mention, Paul Kelly, Fiona Judge, you know, who've made such a brilliant contribution, Zoe Martin, who I know left us earlier as well. Brilliant contributions, really grateful, and just want you to feel warm and fuzzy about the value that we placed on your contributions throughout your term and indeed in all our meetings. So thank you so much. I'll bring the meeting to a close, and our next meeting is on the 11th of May. So look forward to joining that meeting with some new governors in tow that we will have inducted by then. So thank you so much, everybody. Take care for now.
Thanks. Thanks.
Bye.
Bye.
Bye all.
Bye-bye.
Bye-bye.